Hi, I'm Dr. Joseph Wittering, and today I'm joined by Dr. Valsa Madhava, and she is an uh, an internal medicine doctor who specializes in addiction, but also does some integrative medicine work, and lately has been seeing patients who have benzodiazepine withdrawal problems. She's been doing this for a while, and what we'll be doing today is we're going to talk about how Dr. Madhava started, came to treat benzodiazepine patients, doing withdrawals, treating protracted injury, and then also talk about her clinical experience working with these folks and also her experience with functional medicine as well as a treatment for protracted withdrawal. So with that introduction, I'm going to turn it over to Dr. Madhava, and please go ahead, introduce yourself.
So thanks, Joseph, for having me. And so let's have a discussion. So I'm an internist, as you said, and I've been doing straight up internal medicine, general practice for a long time, and also addiction medicine mixed in with it. And I got certified in addiction medicine recently. And also I got certified in functional medicine in the last few years. So for the last several decades, I guess I've been working in different kinds of addiction programs. And almost all the time, when the patients come in for treatment of addictions, inpatient, when we do detox treatment for 5 to 7 days or an opioid treatment program, when the patient comes in, even in the first visit, they think they're getting cured. They think that's all they need to get rid of their addiction. So like it's an antibiotic model, I call it the antibiotic model. They come in, get 5 days of methadone detox for opioid, or the same number of days for benzos and for alcohol, and they really are hoping that they'll never use that substance again. So at that time, when I was thinking about this, and I was also in studying functional medicine at some point, and I just sort of thought maybe functional medicine can help these patients. Now, can we sort of help the patients really, cure is the wrong word, but really help them deal with their addictions better than our conventional model, which is detox and then having them go to rehab, which is basically medication free. So I got into a private practice where I could do a functional medicine model for treating addictions. So the way I was taught, the way I understood addictions was to include benzodiazepine as an addiction, just like alcohol, cocaine, opioids. So I had that model when I started my functional medicine addiction practice. So as I started to see patients, it was the patients that sort of indicated to me that benzodiazepines is not an addiction, it's a dependence. And they really wanted care in a different kind of way. Almost all of them pointed to the Ashton manual and sort of wanted a slow taper over several months, years. And I let them dictate the taper and that's how I ran my practice. It was a very patient-centered model with my guidance. So for whatever addictions they came in with, I had a way of addressing that addiction. But I let the patient sort of guide me in that.
I think an interesting distinction, which will be useful for people listening, is the difference between addiction and dependence. I wonder if you could kind of talk to that and speak to why it's important to not confuse the two with respect to benzodiazepines.
So benzodiazepines is not an addiction. Benzodiazepine use is a dependence. So one of the first things is you can look at the surveys that was done. So there was a survey done in 2016, and it was a survey based on prior year use. So what they showed were that 30.5 million people used benzos the prior year. Out of 30.5 million, only about 5 million misused it. So misused was defined as not using it exactly as prescribed. So if Xanax was prescribed twice a day, then misuse would be if they took it once a day or 3 times a day. But when you look at the misuse, which is 5 million out of 30.5 million, most of those individuals misused it for better sleep, or because they were having an anxiety moment, or because they had some sort of emotional issue. More than 2/3 of them used it for the reasons that you would use a benzodiazepine for. Only 11% used it to get high. And most of those are usually young people, like between the ages of, 17 to 25. But they did show that 500,000 people, so 0.2% out of 30 million, really had an addiction. So that's how so even with that survey, there was just such a small minority that can be classified as an addiction. And yet almost all the benzo users are sort of classified as having an addiction rather than a dependence. And I mean, there's so many other instances. So there was an article that came out in JAMA, it was last year, and the authors just went through the 11 criteria that make up a diagnosis of addiction. Addiction is now called a use disorder. So these authors went through the 11 criteria that constitute a substance use disorder. That was something that came up with the DSM-5 in 2013, I think. And so they went through the 11 criteria. The benzo users only met criteria 10 and 11, which is tolerance and physiologic dependence, which you would expect with any medication, any SSRIs. Almost any medications can give you this. Tolerance is needing to use more of the medication to feel the same. And physical dependence is having withdrawal symptoms when you either take the drug later, take the medication later, or if you miss the dose. So those are natural. Tolerance and physical dependence or withdrawal symptoms are a natural consequence of using the medication. So that does not make it an addiction.
Because when you say addiction, it conjures up images of someone using, methamphetamine or heroin. It's drug-seeking behavior. They're going out, maybe they're spending more of their resources than they should on it, and they're using it for essentially to get high is the idea. They're using it to get that specific psychological effect that is, that is pleasant and maybe euphoric, and that is just so not the case with the majority of the folks that we're seeing with the benzodiazepine problems. And then also, the patients are treated in this way. So many people that I guess come to my clinic will say that they've moved state, and they start up with another provider and they go, oh, you're on a benzodiazepine, this is no good. And God forbid they're on Suboxone as well, because they've had maybe an opiate use disorder in the past. They take one look at that medication list and say, we're pulling you off these benzos. It's going to happen in 2 weeks, and if you're not interested in that, then you can kind of go somewhere else for your drug-seeking, treatment. And that's a sad story, but it's a common one.
So that's the problem with misdiagnosis, miscategorization, because the way you treat a dependence versus addiction is very different. Once you have a diagnosis of addiction, then the pathway there is you send them, especially for benzos, you send them to an inpatient unit for detox, which is basically medically supervised withdrawal for 5 to 7 days. And then you send them to rehab, medication free. So that is not the path for someone who doesn't have an addiction. And I just try to show you why benzodiazepine is not an addiction. So when you can sort of say, okay, benzodiazepine is a dependence, and this is what we need to do for this kind of dependence, because benzodiazepines change the brain. That's the bottom line. And how do we get the brain back to functioning the way it was before it saw the benzodiazepine? And so for that, you need to do a slower taper. You need to withdraw the medication from the brain in a way that it can slowly get back into balance. And the biggest problem with conflating dependence and addiction is not knowing the neurobiology. Addiction is about dopamine receptors, and the reward pathway. That is definitely, for most of patients, that whole system is not involved in benzodiazepines. It's usually the GABA and the glutamate GABA and glutamate neurotransmitter system. So dopamine doesn't come into play that much in this. So just the neurobiology takes you away from the scene of addiction. So you have the survey, then you have the paper that I just quoted from last year, and just the definition of DSM, and now the neurobiology. So you have all different ways of sort of showing this is not an addiction. So, and then to treat them as if they had an addiction is such a grave disservice to the benzo using community, I think.
Yeah, and dangerous as well, because if someone gets tapered too fast, a lot of the anecdotes that I hear is that ends up being the precipitating factor for problems like bind, are these rapid tapers. And so I want to ask you, so since you transitioned to your private practice, to your clinic now, what's your experience like treating benzodiazepine dependence? How's that been going?
So when I started, so okay, in my practice, what I do is I collect a lot of information,
Mm-hmm.
and then I do a lot of testing, and then it's based on the physiology, right? Like, so we have the patients change their diet, movement is a big part of it, and then other kinds of modalities, and includes supplements. So that's the framework for functional medicine. And so I did that, got a lot of information about the patient, and, ruled out certain things, ruled in other things, and then did a lot of testing. And while we were waiting for testing, we started some supplements, and then did a very slow taper. And the tapering was completely determined by the patient. I would just sort of give them advice. So I'm not sure that everyone needs to change to Valium. I think they can perhaps taper with the medication that they're on. So I would recommend for them to remain with the medication. But almost all of them had read the Ashton manual, and they all wanted to change over to Valium.
Well,
So
yeah,
then,
tell us about that. What's your experience like? I guess because probably initially you were like me, and you probably tried to put people on Valium, or maybe you're not. But I'd love to hear about your experience attempting that, and why you've kind of landed in this place where, hey, maybe we'll just try and taper you on um on what you're on.
so sorry, we need
It's
to cut
okay.
that.
Yeah.
It was my daughter.
Yeah.
Um, all right. So in terms, can you repeat the question?
Yeah. Yeah. No, that's okay. So I was going to say, you mentioned something that goes counter to the Ashton manual, that, maybe we don't need to swap people over to Valium. How did you come to that decision?
Because patients, when they switch over, the vast majority have trouble, actually.
Hmm.
And they have trouble during the switch, and just, I don't know exactly why, but actually this brings up another point, is when docs and facilities decide that they don't want to give a certain benzodiazepine and they want to give another one, that also creates the same problem, because we're not sure what's happening in the brain, that it's sort of, in quotes, used to one benzodiazepine, and when then you substitute another one, it still goes through changes. I can give you an example of what happened in Louisville, Kentucky, I think. There was a county there that decided in 2011 that they would stop giving Xanax. That was because they were having a lot of overdose
Hmm.
deaths, combination of benzos and opioids. So they decided, okay, we're not going to give Xanax because that was the most prescribed substance. Okay, that was a fine decision. But then the next decision was, we are going to taper patients off of benzo, or switch patients, all the patients that are on Xanax, we're going to switch them over to Klonopin.
Hmm.
And so that, when I read that, I was just like, wow, that is like a horrible thing to do, because yeah, many patients will do fine, but there are a certain number of patients that don't do well with the switches. Even though it
Yeah.
feels like it's a longer acting, it doesn't matter to the brain. The brain just doesn't see that. It just sort of sees it's a different medication, and it goes into some sort of disequilibrium. And anyway, that was what was done. I don't think that was
But that
we could.
makes sense, right? Because, I think, like you mentioned, I mean, the main rationale for swapping people over onto Valium is, this medication has a much longer half-life. You're going to have less fluctuations in your serum concentration of the active ingredient, kind of at the neuron. But there's a lot more to it. There's, I guess, what we would call the pharmacodynamics, which is the interaction of the chemical with the actual neurons. And, Valium and, Xanax, presumably they will have different, they're different chemicals. They'll have different effects on the neurotransmitter systems. And so ultimately, I feel like sometimes it works and it can treat some interdose withdrawal type symptoms, but for a lot of patients, they don't do too well. And, they'll either become, I guess the main thing with the Valium is the complaint of some cognitive dulling and also maybe some depression as well. And so I started to tell people it might be better to dance with the devil that and if you're on Xanax and you're taking it twice a day, but you're having interdose withdrawal, we'll stay on the Xanax, but we'll split it into, 3 or 4 doses over the day, and move forward in that way.
Yeah, I agree with that.
Yeah.
And I think the taper that
mhm.
Dr. Ashton also recommended maybe too fast for some people. So I often tell patients that the dose reduction that she recommends may not be the right tempo for them. They might need to slow it down. And sometimes
Yeah, what do you find it to be like a good rate from your experience?
it all varies, probably depending on where they are. Like it's a whole spectrum of patients, right? Some patients can do well, right? Like the standard, what do they call in conventional medicine, they do like what, 10, 25% every few weeks. That's like so rapid. I don't think that many patients will tolerate that, but perhaps some will. I think 2.5, 5%, and every week, every 2 weeks would be
That's
pretty.
interesting. Yeah. Yeah, I landed at about 5 to 10% every 3 weeks. And then some people want to do it in 2 weeks and some people want to do it in 4 weeks. But it's a mixed bag. Okay, that's interesting. The other thing that I thought was unique about your practice is that you do a lot of the functional medicine testing and supplementation before you begin the tapers. I was wondering if you could speak to why you do that and what you believe the benefit is in I guess optimizing their health with the functional medicine before initiating the taper.
I think stability. I think I'm looking for stability in the patient so that they
Mm-hmm.
can undergo the taper. I think patients still have difficulty, even though it's a tiny taper down. There's still disturbances in the brain that they still have withdrawal symptoms, even with that small decrement. So trying to get them as stable, as fully functional as possible before they start the taper. But of course, many patients are so eager to start the taper like right away. So we may not get them to that right level of stability that I would like. And I don't necessarily wait to get the results of the testing before I start the supplements. Oftentimes I'll just guess on the supplements, some standard ones, but it's not standard for everyone. Everyone is different and many patients have side effects to the supplements. So you have to be really careful with them. Yeah, so that's what I would say is, and then once you get the results back, then it's much easier to give supplements because then okay, you're deficient in this, and then you monitor for side effects. I think the gut is always implicated in this. We need to have a good, strong gut. I think the benzos probably affect the gut microbiome, which are these organisms that live in our GI tract, which is between the mouth and the anus. There's this long tube, and in the large intestine, the latter part of this tube, there are these organisms that live there naturally. They're about, I think, about 3 pounds worth of organisms there. And they're there to help us. We've evolved over the millennia with them. And so they're there to help us. They synthesize vitamins for us. They do a lot of they give us a lot of beneficial metabolites. So it's good to have those microbiota in the right proportion. So I think many things affect the right balance. And I think benzos might be part of it, but also our diet, the chemicals in the air, the water that we drink. It's very easy for us not to have the right balance. So once I get that test, I might do some tweaking there. And then if there are nutrient imbalances, And so, yeah, I start some supplements early and then some later.
Are there any supplements that are specifically useful for benzo withdrawal, or does it really just kind of depend on how the tests return from the patient?
I think magnesium is a good one. I think
Okay,
magnesium
sure.
is good. Um, and anything that maybe B6. I like
Hmm.
B6 because glutamate is the father of GABA or the
Hmm.
mother of GABA. So to go from glutamate to GABA, you need B6. So that's fundamental. It doesn't seem logical that you have the excitatory neurotransmitter, leading to the inhibitory
Hmm.
neurotransmitter. So if you give B6, if they're deficient, so you might be able to sort of push that path a little bit more towards GABA.
Okay, great. And
B6.
is there a kind of a diet that you recommend just generally for patients when they come and see you and they're looking to kind of optimize their overall health before beginning a taper?
Yeah, a low glycemic diet, not too much sugar and processed foods, no caffeine. And the reason is because hypoglycemia, low blood sugar symptoms are similar to some of the benzo withdrawal symptoms. Like you can have anxiety and sleeplessness, waking up in the middle of the night with low blood sugar. And in fact, there was a study in 1966 which showed this particular doc, he did an evaluation. At that time, they were doing 5 and 6 hour glucose tolerance tests. And he did glucose tolerance tests of all patients who had come to him with a diagnosis of a neuropsychiatric diagnosis, but he decided to do an OGTT on all of them. And he found that a lot of them, like a significant number of them, had hypoglycemia. This is even before our diets changed in the 70s and 80s. And what he also found that some of these patients were on anxiolytics. So the question is, were some of these symptoms of anxiety and sleeplessness due to hypoglycemia, and then they got treated with, either barbiturates or benzodiazepines because that was what was available then. That's a question, right? So are we giving benzos to patients who might have hypoglycemia? And then the other reason to think of
Hmm.
hypoglycemia, benzo is not an addiction, but in a lot of the addictions, hypoglycemia is very, very common. So I always think about a low carb, low processed food, high protein, high-ish fat diet, and then eating several times a day, not just a couple of times, really separating the meals so that you have a steady influx of nutrients.
And why does cutting carbs, I guess the processed food and the simple carbohydrates like the sugars and wheat, flour, that kind of stuff, why does that regulate your blood sugar levels so you're not having hypoglycemia? I don't know if you can speak to kind of what it is about that diet that makes it people just more stable, dropping those foods.
So processed foods, because it affects the gut microbiome, but
Okay.
even processed foods can, so carbs in general, what happens is carb is essentially broken down into sugar molecules. So carbohydrates are complexes of sugar molecules. So when you eat them and they're digested into smaller molecules. So when the sugar hits our system, is absorbed, the body tries to deal with it. And the way it deals with it is by releasing insulin. So what
Hmm.
the insulin in the blood does is it gets rid of the sugar, so the sugar doesn't stay in the blood. And depending on the amount of sugar that you eat, you might have a lot of insulin that's secreted by the pancreas. And so you might have a dipping of the sugar level in the blood. So you have low blood sugar for some period of time because of perhaps the excess insulin that's being secreted by the pancreas. So at that moment, when the sugar is so low, you might have jitteriness, you might have anxiety. So that's when, if you have different kinds of addictions, you go to the drug of choice. And maybe with the benzo, you're becoming anxious at that moment. And you may think that anxiety is due to maybe interdose withdrawal. I don't know. I'm not sure, but I'm just sort of saying that steadying the sugar in your blood is a good thing to do. So eating regularly so you don't have these highs and lows of sugar in your blood is a good
And
point.
what do you think about like because the diet you described, it's kind of heading towards a more ketogenic diet where you said high fats, meats, and then I guess more vegetables. Do you think I mean, is that a diet that you think is useful? I guess for benzodiazepine withdrawal and these kinds of anxiety as well. I don't know if you have experience using that kind of diet.
So ketogenic diet really means that you have ketones in the urine or in the blood.
Hmm.
So achieve ketogenic ketosis, you need to eat less than 25 grams, 25 to 30 grams of carbs. That's very hard to do. You really have to be dedicated and devoted to that mission of getting ketotic. So ketogenic diets in general. So I don't know if you've been following the literature. It shows that ketogenic diets are good in the mental health space, right?
Hmm.
Like for schizophrenia, for bipolar. And the reason is because there's a lot of dysregulation of using glucose in the brain cells. So the brain cells are not able to use glucose, and that's the same mechanism for Alzheimer's. I don't want to get into that, but the brain cells are having difficulty using sugar for fuel. So when you have ketosis, you have a different kind of molecule called beta hydroxybutyrate, which can be used as fuel for the brain cells. And so that's why they were thinking that if there's sugar dysregulation at the brain level, then perhaps a ketogenic diet would be useful for many mental health disorders. So specifically for benzodiazepines, I'm not sure. It's a very hard diet to follow, and the patients are already suffering. They already have
Hmm.
gut issues. Patients have been losing weight. It's not the first thing that I would think of for a patient who is trying to get away from benzodiazepines. I think we need for them to probably eat more and then, take care of their gut and then give them the right kinds of supplements. And eventually you can pull back the supplements if they're eating well, right? If we get to that point. But a lot of patients have a lot of issues with eating and with having a good diet.
Great, thank you. That was a really educational response. I want to shift and ask you a little bit about what do you think are the biggest challenges in treating benzodiazepine dependence?
So in my practice, I think I'd probably get tough patients, just like I'm sure you do.
Hmm.
I think, when I went in with the functional medicine framework, I thought that if I, took care of the gut, if I took care of some of the nutrient depletions, that they would do better with their tapers. And in general, they do better. They are able to go through the tapers. They might be able to go back to work. They might have less social and work dysfunction. But I think there's still a lot of difficulty with the taper. Like when patients are getting to the point of to decrease their dose, a lot of patients still have symptoms around that. So I think functional medicine may not be the complete answer for that, for those patients that are having a lot of difficulty with the tapering. I think there are other disruptions going on in the brain. It's not just about GABA and glutamate. Like I was thinking it's mitochondria, which is what we're saying with the ketogenic diet. What you're doing is trying to give a different kind of fuel for the mitochondria rather than the mitochondria having to process sugar. Now they're processing beta hydroxybutyrate or something else for energy, which
Yes.
is
So, oh, sorry, you were saying?
no, you
Yeah.
can go.
What do you think is going on with bind? Because you were talking a little bit about, underlying pathophysiology just before. I'd love to get your perspective on because I mean, we spoke before this. You do have some patients in protracted withdrawal slash bind, and yeah. What do you think is happening with them?
So I've spent tons and tons of time actually trying to figure out what's going on. So there's some calcium dysregulation at the cellular level. And so there's certain, like we have ion channels, with
Mhm.
the the GABA receptor. We also have different kinds of other channels like calcium channels. It seems that there's some sort of calcium dysregulation, more calcium getting into the cells. And that causes things like oxidative stress, meaning you have extra oxidants. So oxidants are these free radicals, these molecules that have unpaired electrons on them. So these radicals can cause a lot of damage to different components of the cell. And maybe because of the glutamate and this calcium issue, I think there's a lot more of this oxidative stress going on. It's good to have a limited number of these free radicals, but if you have too much, then that itself can cause problems. So I think that's a big issue. And there are different kinds of free radicals, and how do we deal with them, and what's the damage that they have caused. So it's to look at that a little bit deeper. And I've known that oxidative stress is a problem, so I've tried to deal with it with supplements. But the supplements I've been using so far is not necessarily the complete answer for bind. So I keep looking and trying to figure out. So I do a lot of, let's say, literature-based usage of different kinds of molecules. So everything that I do is based on the literature, and then I try to use literature from, say, the Alzheimer's world or the Parkinson's or autism literature, and sort of say, okay, what's similar about the dysfunction that's happening in those disease states that I could apply to bind to this severe dysfunction that's going on for some proportion of patients. So that's what I'm working on right now, is to sort of see, can I use other molecules? So I'm starting to use peptides. So with peptides, it's mostly around trying to make the patients feel better, the stabilization part in the beginning before we start the taper. So I'm using peptides to see if we can make a difference. I'm not sure that we can. It's just, we know that some of the peptides can affect the GABA receptor, is to sort of see, okay, if we do that, can we help the patient? It's all theories on one side, but when we actually use it, does it really work? So I'm trying to figure out if, theoretically, I know that they affect the GABA receptor. Now I'm using it. Does it really work? And so far I can tell you, maybe yes, maybe no. So there's no definitive peptide that I've found so far that is it. But I've just started to use peptides in my practice.
That's interesting. And I mean, for me, I mean, part of that is what actually makes medicine fun. If you can take these evidence-based experiments and, work with your patients to try and find new things, especially for these, I guess, these illnesses which aren't well known. I mean, I've done countless trials of different medications for people who have been having bind. I think I've tried probably every single migraine medication, every single typical medication for neuropathy. There's, I think, yeah. So, I mean, that's exciting. Have you stumbled across anything that maybe in just one patient it made quite, a noticeable difference?
So different patients come in with different symptoms,
Mm-hmm.
right? So I don't use necessarily the same peptides. So there was one patient who had sleep issues, and so I used a particular peptide with him. And so I'm waiting to see. It sort of helped him, but 1 or 2 days is not enough for me. It has to be consistent. So I don't know, that might be the peptide that helps him. Then there is another peptide that sort of is supposed to affect the GABA receptor. And I thought, oh,
Mm-hmm.
great. No, it hasn't really made a difference. So just like using, as you said, using the literature in innovative
Mm-hmm.
ways to lessen the suffering of many of our patients. That's sort of the goal. And once we figure out I guess my goal would be really trying to figure out what is the root cause of these bind symptoms, right? There has to be something, maybe not one thing, but I really think that oxidative stress, or if I dig deep enough, I think I'm hoping that I can find something that I can address with the patient. So that's my hope. I
Yeah,
spent countless hours looking for this, so I don't know.
yeah. I don't think I've thought about it as deep as you have, but the thing that kind of sticks out to me is, especially just based on the anecdotes of people who seem to develop the injury acutely after an abrupt withdrawal, is there's something about when, I guess, you pull out the the benzodiazepine, and then you no longer have this external substance, providing that presence that the body is used to, and then with that gone, then you just have glutamate and the excitatory neurotransmitter system, essentially functioning without any breaks. And maybe there is something about that is destabilizing, maybe causing dysregulation in calcium and the production of free radicals. But ultimately, what I think is happening at that point is, whether we want to call it free radicals or something else is going on, is that there's actually neuronal damage. That there's because what we find, and you've probably seen this, is they'll go through the acute withdrawal, or they get tapered too rapidly. They develop the full bind spectrum of symptoms, and then you put them back on the medication, and they still have all the symptoms. They're extremely uncomfortable, and they're back on their regular dose. And so there's been some kind of lesion, like an injury that's taken place in the meantime, and then they're just back on their previous dose, but they have all of those symptoms. And then the clinical course also seems to suggest injury, because it takes months to years to improve over time, which seems to suggest to me that this is the brain just slowly, I guess, rebuilding whatever was damaged. Yeah. So if someone wants to come and they want to see you and go to your practice, where are you? What should they know? Tell us a little bit about that.
So I have a practice in New York, and I can sort of do telemedicine for the functional medicine side of it elsewhere. And it's really a concierge practice, meaning that when patients come in, they pay us a fee for all the services. So that includes all the testing. And I would say at this point, almost unlimited visits with me. So that means that for some patients, I'm in daily touch with them, and I meet with them, twice a week, but we have frequent contact with our patients, especially patients who are really suffering. They need a lot of contact, and we're working with different supplements also. So that's another reason to have a lot of touch points with patients. So it's a practice that, they pay one fee and they get a lot of services, including me. Then I have a mental health consultant who works with us. There's a nutritionist who works with us, and also a mindfulness and meditation coach. And then all the supplements are included. And so because it's one fee, it gives me the freedom to try different kinds of supplements, different kinds of molecules. And also often I find that patients who are affected with benzodiazepines, they've already done their research, right? Like they know so much, and often know more than you. Actually, that's how I learn, right? And so they're also coming to me with things that they might want to try. So this gives both them and me the freedom to try different molecules, different substances, to see if that'll make a difference in their health. So it's one fee, and then there's a monthly fee. And so that's how the practice works. And there's no fee for service, unfortunately, just because that's the kind of practice we have at this moment, is to really try to understand what's going on and trying to make the patient feel better. So I call it the model.
Yeah. And do they have to be in New York? Can they be in any other states to see you?
Yeah. For now, as a New York, Connecticut, and of course, those are adjacent states. And then I'm trying to get telehealth licenses elsewhere. But if they have a prescriber and they just need the other part of it, which is the functional medicine part of it, that can be done anywhere, because then I become a functional coach, basically, or consultant. They don't need me for the prescription part of it. So that can be done across the country. It's when they need medications that there is some legal and our board requirements for what needs to be done.
Okay, great. I've covered all of the questions that I wanted to ask you. Did you have any other final thoughts or anything that you think is important to talk about?
No, I think we covered most of it. I guess it's just that, the taper needs to be slow, and to find a provider that's kind. I think that's the hardest thing to do, is to find someone that's kind and just willing to work with you. I think that's where us as benzo wise providers need to, go out there and educate other providers to provide the service for patients who are really in need.
Great. Well, thank you so much. It's been a pleasure talking to you. I hope we can stay in touch. And yeah, I really appreciated your insights and your clinical experience working with these patients.
Thanks, Joseph. Pleasure meeting you and being here.
Okay. All right. Bye.